The second big and actually the most common inherited bleeding disorder is von Willebrand disease. Von Willebrand factor is a glycoprotein that's being produced constitutively in endothelial cells, megakaryocytes, and subendothelial connective tissue. It's being produced as a very big molecule and needs to be cleaved into smaller units, eventually through the activity of a metalloproteinase, which I will mention later. Von Willebrand factor itself is not an enzyme, it's really just a protein, but it has two important functions. Number one is it helps in the platelet adhesion process of platelets being, or platelets adhering to endothelial surfaces. So adhesion is number one, sort of a bridge between endothelium and platelets. And number two, I just mentioned it, it's sort of a chaperone for factor VIII. It blocks its degradation, it maintains its half-life. So these are the two major functions of von Willebrand factor. There's three major types of congenital von Willebrand disease. You don't have to memorize them. The most common one is type 1, that's sort of a partial deficiency of von Willebrand. Type 3 would be complete absence of von Willebrand factor. That means then also that factor VIII doesn't function well, or it's very low level, and almost looks like hemophilia A. But typically, in the most common form, not. Acquired versions exist as usual. I told you before, the usual culprits are connective tissue disease, malignancy, infection, drugs. It can also just come with age and the production of antibodies against von Willebrand factor that leads to deficiencies. The clinical manifestations is just mucocutaneous bleeding. Think GI, ENT, nosebleeds, fairly common, and think GU, menorrhagias or postpartum hemorrhage. So GI bleeds, GU bleeds, and ENT, mucocutaneous bleeding. You can measure the levels themselves. You can also use functional assays like the ristocetin cofactor assay. The one thing you have to memorize with measuring levels of von Willebrand factor, they fluctuate a lot, and they depend on whether or not people take estrogens or birth control pills, for instance, whether they bleed, they exercise a lot, or God knows what. So you may sometimes have a von Willebrand disease and kind of get that blood draw at the wrong time in a woman who is on birth control pills, and the levels may look normal. So keep that in mind. The von Willebrand factor levels are influenced by some of those states. Treatment is with desmopressin. I said before that desmopressin releases von Willebrand factor from endothelial cells. In more severe cases, you can also use factor VIII concentrates and other plasma coagulation factors. A form of acquired hemostatic defect is the presence of coagulation factor inhibitors, antibodies that are being produced mainly against factor VIII. That's also something that can simply happen idiopathically with age. You also find it in malignant conditions, lymphoproliferative disorders, autoimmune diseases, in a lot of cases idiopathic. You treat this again with concentrate replacement as shown on the slide. Coagulopathy of liver disease is obviously also acquired. The liver produces almost all of the coagulation factors. One exemption is factor VIII. It usually tends towards a hemorrhagic picture in liver failure, not so much of a clotting type picture. You have abnormal and low levels of fibrinogen, splenomegaly, thrombocytopenia, consumption of platelets in DAC and other processes, typically correct with FFP or vitamin K. Even if patients with liver disease have elevated PT-PDT, don't assume they're automatically anticoagulated. As a matter of fact, they still have a thrombotic potential, so they may develop clots even with elevated PT-PDT. Disseminated intravascular coagulation results from abnormal thrombin generation and an overproduction of the whole coagulation cascade. So clotting factors are being consumed, platelets are being consumed, and you have a generalized sort of bleeding condition. Typically, you kind of diagnose it in the right clinical context with abnormal clotting factors, thrombocytopenia, very low fibrinogen levels would go with it as well. In microangiopathic conditions, you also find schistocytes on the SME and other signs and symptoms of hemolysis. So you treat the underlying cause and replace patients with clotting factors, FFP or cryoprecipitate, in particular for fibrinogen. There's many different courses of DIC. We deal deal a lot with malignancy and leukemias or septic conditions. Another big group are actually obstetric complications. Now, let's look at platelet disorders. Normal platelet count, 150 to 400,000. The bleeding risk is shown here. It becomes really substantial if you go below 20,000, certainly in the single-digit range. Above this, actually only with surgery or trauma. Etiology of thrombocytopenia is shown here. The first question, if you have a patient with a low platelet count, is actually, is it a real thrombocytopenia or a pseudo-thrombocytopenia? In other words, are the platelets clotting? There's about 0.1% of the population who have EDTA agglutinins, and if you collect platelets in an EDTA tube, they will just agglutinate to each other. So this is something you want to exclude by looking at the smear, and then if need be, kind of use a different form of anticoagulation, citrated or heparinized blood. So that's your first question. Is it true thrombocytopenia, or they're just clotted together? The second question then is it an isolated thrombocytopenia, just the platelets, or is it not isolated? So are the white cell concerned, the red blood cells, are they schistocytes on the smear, or other signs and symptoms that would indicate a more systemic disorder? Otherwise, the etiology is hypoproliferation from various marrow disorders, and the marrow may look any particular way. It may be empty looking, it may be hypercellular, it may look otherwise normal cellular. Think of sequestration, so splenomegaly is one potential reason for thrombocytopenia, and peripheral destruction. Immune-related peripheral destruction typically is associated with isolated thrombocytopenia, so it would not affect other counts, and that means ITP primarily. Non-immune causes, I mentioned a few before, typically not, so they show more changes in your smear. So immune thrombocytopenia is your poster child, isolated thrombocytopenia through autoantibodies against platelet surface proteins, females more affected than males. The manifestations vary a lot. It can be from mild to more severe with bleeding complications according to how low the platelets will drop. It's usually a diagnosis of exclusion. To test for the platelet antibodies is not helpful. It's not specific and not sensitive. You exclude other potential reasons for thrombocytopenia. If you did the bone marrow, you would find possibly an increased number of megakaryocytes, but that's not a very reliable indicator either. So it can be an isolated condition by itself. It can sometimes be in association with other medical conditions like lupus or lymphoproliferative disorders or other autoimmune disorders. The treatment frontline is based on steroids. Usually people use prednisone on a 1 milligram per kg basis for a few weeks and then taper it off. It seems to be more efficient to use a shorter course of dexamethasone, but that's, I don't think, relevant for the boards. IVIG, intravenous immunoglobulins, may help fairly rapidly, but the effect of IVIG is not long-lasting. It may only be for 2-3 weeks, and the platelet count would drop back again. In more refractory cases, a second line, use rituximab, an anti-CD20 monoclonal antibody. Splenectomy, as a matter of fact, is very efficient and has probably the highest percentage of long-lasting responses, about 65%. Nowadays, you also have approved by the FDA thrombopoietin agonists, thromboplostim and L-thrombopag, which can be quite effective, but you have to take them long-term. So another important condition in association with thrombocytopenia is heparin-induced thrombocytopenia. There's two types, actually, type 1, type 2. Type 1 is a non-immune kind of related heparin-induced thrombocytopenic condition, which is clinically not so important. It may be more frequent, but it doesn't have any dire consequences. The important one here is type 2. That's an immune reaction where your body builds up immunoglobulin against a heparin platelet factor 4 complex. That may happen in 1 to 3% of patients being exposed to heparin. It's much more frequent following exposure to unfractionated heparin, say low molecular weight heparin. So that's one of the reasons why people push to go away from unfractionated heparin and rather use low molecular weight heparin, say where you have to prophylax in surgical patients or the likes. It's also more frequent in surgical units, say cardiothoracic, orthopedic surgery, not so much frequently in medical units. And it's actually also less frequent in intensive care units, partly because patients are so complex. There are so many other potential reasons for thrombocytopenia that doesn't quite qualify all the time. There's a very characteristic time curve for the development of HIT, usually within 5 to 10 days after exposure of heparin. The only exception being it can kick in very quickly if you had been exposed to heparin before. So that's the only kind of exception you have to keep in mind. The platelets decrease by about 50% from baseline, but they usually do not go down to very low levels. So single-digit platelets, 20,000, would be a little bit unusual for HIT. Importantly, many of those patients, 30 to 50%, suffer from thrombotic complications, mainly venous thrombotic, but it may also include arterial thrombotic complications. There's two types of tests. One is a ELISA test that will just show you the platelet factor for heparin complex. That is, if it's negative, has a very high negative predictive value, almost 100%. So if this ELISA is negative, you can almost exclude HIT. If it's positive, on the other hand, it doesn't help you much. It's not very good there. So that would mean you have to do the next test, which is a functional assay, serotonin release assay. There's been, I'm sure you're aware of it, clinically the 4T score, which allows some measure of predictability, how likely it is to diagnose HIT, and it summarizes nicely actually the important factors because they all get the highest scores. Number one is the decrease in the platelets. I said more than 50% and typically not very low. That's the first one. Timing within 5 to 10 days, not right away and not a month later. The presence of thrombosis, and you have excluded other potential reasons for thrombocytopenia. So these four factors will give you the highest score and make it most likely that you deal with HIT. The management is straightforward in that you have to discontinue heparin in all forms. Flushes, prophylaxis, impregnated lines with heparin. So no heparin and not any heparin in the future either. So they should not be re-exposed. You may want to avoid platelet transfusions, especially as long as platelets are very low, because platelets in the endothelium get activated, so may actually increase the potential for thrombotic complications. Oftentimes, actually in most cases, you will have to think about switching to another anticoagulant from heparin, and the ones that are most frequently used probably are gatroban, bivalirudin, and maybe in the United States, fondaparinux, although the latter one is not FDA approved for it. You may obviously have patients with HIT who do not have a thrombosis, where you think you may just stop the heparin and that's it, but the risk of thrombosis for those patients, for developing thrombosis in those patients, is still fairly high. So you would still be better off treating those patients with one of those alternative anticoagulants until the platelets are normal. The other one to remember here is you do not start patients on Coumadin until the platelet count is at least 150,000 or higher. Otherwise, you risk severe clotting abnormalities, or necrotic skin reactions and the like. TTP and HUS are important medical conditions. I mentioned it in other contexts before. It's always important to keep this in mind. You have abnormally activated platelets and endothelial surfaces, deposition of fibrin in the microvasculature and the hemolytic process, destruction of red blood cells and platelets. HUS is typically a triad of thrombocytopenia, the manifestations of hemolytic anemia, the schistocytes, plus renal failure. In TTP, it's sort of a pentad, oftentimes, in addition to the three mentioned changes in mental status, neurological manifestations, and plus-minus fever. None of this is reliable. The only two that really matter is thrombocytopenia and microangiopathic hemolytic anemia. If you see this, you might want to assume it's TTP and treat accordingly. Don't rely on renal failure. That's a good pointer for HUS, but don't rely on mental status and fever by no means. TTP may occur sporadically through the production of autoantibodies against ADAMTS13. That's a metalloproteinase, I mentioned it before, that cleaves the very large von Willebrand factor multimers into smaller units. If this enzyme is missing, von Willebrand factor will not be cleaved into small units, and it will be hyperactive in attracting platelets, adhering platelets, and activating the endothelial surfaces. And that leads to thrombotic complications in various vascular beds. So you test for ADAMTS13, you send it off, but it takes a while for this test to get back. So you cannot wait for the results until you have a confirmed TTP. It should be less than 10% in TTP, or is it atypical HUS, you know? So your treatment would still be the same. You can find it secondarily from drugs, HIV, AIDS, or other conditions as well in the transplant world, for instance, as well. That diagnosis I mentioned before, important is the management. So if you recognize and treat TTP, you can turn a condition that's 80% fatal into one that's 80% survivable and manageable. Your mainstay of treatment is plasma exchange for as long as it takes to increase the platelet count to more than 150,000. Steroids do not play a big role. You might want to give them, but steroids by themselves are not useful. If there is a delay to plasma exchange, you can give FFP, but plasma exchange really is your major cornerstone of treatment. There's a number of disorders of platelet function that involve adhesion, aggregation, or granule release. Some of them are acquired, some of them are inherited. The inherited are so infrequent that it's really useless to remember them, but they're always around. Bernard-Soulier is an adhesion disorder that affects GP1B on the platelet surface, or Glanzmann's as an aggregation disorder that would affect GP2B. Doesn't really matter. So it's really a minor point. Thrombotic disorders, summarized in the traditional classic Virchow triad: stasis, vessel wall integrity, and hypercoagulability. Hypercoagulable state may be acquired or inherited. We suspect inherited in patients of younger age with unusual locations of the clot, splanchnic or cerebral vessels, for instance. Recurrent or pregnancy loss, or a family history of thrombotic disorders. There's a number of inherited conditions listed here on the slide. The most common but least potent is actually factor V Leiden. Then you have prothrombin mutations, hyperhomocystinemia. On the other end of the spectrum, protein C or S deficiency or antithrombin 3 deficiency are the least common, but the most severe type of clotting disorders. They are rare, but they are usually early in onset, typically cause unprovoked clotting episodes, and have a very high risk of recurrence. Also, in nephrotic syndrome, for instance, you actually lose protein C, S, or antithrombin 3 deficiency, so that's one of the reasons why you have a higher thrombotic complication rate in nephrotic syndromes. You just lose some of those anticoagulation factors. So factor V Leiden is the most common inherited thrombophilic disorder. It increases the risk of venous thromboembolic episodes by 5 to 50 times, according to heterozygous versus homozygous mode of inheritance. It sounds quite a lot, but if you look at the absolute risk, it's actually lower. If you see this 0.5 to maybe 2%. Importantly, factor V Leiden tendency to clot may be increased or aggravated by other aggravating conditions. So if you have factor V Leiden plus, you take oral contraceptives and or you travel or immobilize yourself for a prolonged period of risks, this clotting risk may increase substantially. It's venous thromboembolism, not arterial thromboembolism in factor V Leiden. AT3 deficiency, as I said, is rare, but it's a way more potent thrombotic disorder. It usually starts early in life, 20s, patients in their 20s. It often recurs and leads to unprovoked thrombotic episodes. Acquired thrombophilic disorders are much more common and probably more important. The three major conditions is surgery, trauma, and cancer. The risk in surgery patients is substantial, more so inpatient versus outpatient. And it's not just a higher risk immediately around the surgical episode, but weeks to months actually afterwards. So you have to keep this in consideration if you prophylax patients. With VTE prophylaxis, you can reduce this risk substantially by 50 to 60%. Cancer patients also have a high risk of clotting episodes, more with some patients, more with some cancer types than with other cancer types. And here as well, I mean, VTE prophylaxis can reduce the risks substantially. Antiphospholipid syndrome is one example of an acquired disorder that leads to a thrombotic range of thrombotic complications, venous and arterial thrombotic episodes, miscarriages, thrombocytopenia, vasculitis, renal insufficiency, and other abnormalities. It's due to antibodies that can be detected in 1 to 5% of adults and are directed against phospholipids or phospholipid-binding proteins. I would skip those criteria. I don't think they matter for the boards. There's a very severe form of antiphospholipid syndrome, catastrophic, which leads to widespread thrombosis and multi-system organ failure, which may be triggered by infection, surgery, or sometimes if patients discontinue anticoagulation or immunosuppression for an autoimmune disorder, for instance. This syndrome has a high mortality rate, about 50%, requires anticoagulation, steroids, IVIG, plasma exchange, similar to TTP. I think you have this slide also in your handout. This is sort of a differential diagnosis of catastrophic thromboembolic disorders in general. It's taken from a recent blood paper, which actually was a pretty good one. If you want to read this, I think it's worthwhile in the medical service as well. I won't go into detail, but it puts this a little bit into context of conditions with severe thrombotic manifestations. Thrombophilia testing is mainly useful in patients who have a high yield that you will find something, and only for patients with venous thromboembolism, not with arterial thromboembolism. Whatever you test, it will not give you any information about how long you should anticoagulate a patient. The highest yield populations are younger patients, less than 40 years, with a positive family history, unprovoked clotting episodes in unusual sites. I said before, splanchnic bed, but Chiari otherwise, cerebral thrombotic episodes, recurrence of thrombosis, for instance. Treatment of thromboembolic episodes is oral anticoagulants. Last year I had warfarin is a mainstay, but that's not so true anymore. A lot of people use nowadays the newer ones, direct oral anticoagulants. Usually low molecular weight heparin is superior over unfractionated heparin for the acute therapy, so you would hardly use, I think, unfractionated heparin anymore. Low molecular weight heparin definitely better than warfarin, and not quite established vis-a-vis direct oral anticoagulants of the newer variety in patients with cancer, so don't use warfarin, and be a little bit reluctant in terms of the newer anticoagulants. In patients who have VTE with massive hemodynamic compromise, you should try for thrombolysis. I think that's one of the answers the board wants, rather than thrombectomy. So prefer thrombolysis over thrombectomy. IVC filter placement, be very conservative with it. I think the push is really much away from it, unless for very specific combination situations where you just can't anticoagulate in any other way. Duration of treatment for distal DVT provoked 3 months. Any other condition typically longer, at least 3 to 6 months. If you have unprovoked clotting episodes, or in the context of conditions that will just persist, cancer is a good example, typically lifelong. Prevention of thromboembolic is ideally through pharmacologic means. The Venodyne boots you can do, but they are less or inferior to pharmacologic prophylaxis. In medical patients, the unfractionated heparin is somewhat equivalent to low molecular weight heparins. One downside of unfractionated heparin is the higher risk of HIT, these platelet 4 heparin antibody production. So you may want to avoid it for this reason, but otherwise, if it wasn't for this, it's similar active. In surgical patients, patients with cancer prefer low molecular weight heparin over unfractionated or warfarin and others. Be careful, however, look at creatinine and renal function. If you have a patient with renal compromise, you should not use low molecular weight heparin, so that would still be a reason to use unfractionated heparin, which you can use in patients with renal failure. Remember that VTE prophylaxis has to persist beyond the time of surgery for a few weeks because the clotting risk is still very high. Okay, now we switch completely to a different topic, and we sort of slowly are moving into the malignant hematology. Bone marrow failure syndromes. This slide summarizes quite a few of them. The two big ones that are worth mentioning or memorizing for the boards is myelodysplastic syndrome on the one hand, and aplastic anemia on the other hand. They overlap, as you can see, and there are several smaller or less frequent conditions that sort of circulate around those two sort of major conditions. There's a lot of sort of differentiating factors that make one more likely than the other. You can sort of go through this at your leisure. I think it goes way beyond the internal medicine boards to worry about CD34 positive counts in one versus the other condition. But the two major conditions for marrow failure, interesting in medicine as well, is MDS and aplastic anemia. I will touch upon some of the others a little bit. That's a typical bone marrow picture of aplastic anemia. It's predominantly empty with a few islands of hematopoiesis here and there, but not many. The normal cellularity in a somewhat middle-aged patient should be around 40%, 40-50%, and here you come maybe just about to 10%, 5%. So that's a typical marrow picture in aplastic anemia. And in addition, not surprisingly, you have the combination of that plus pancytopenia. Most of the cases of aplastic anemia are acquired. Drugs, toxins, infections, radiation exposure is something you have to keep in mind. If you work up a patient for suspected aplastic anemia, you usually get a pancytopenic patient, so your workup is really pancytopenia. So you look for bone marrow, clonal abnormalities, cytogenetics, B12, folate, thyroids, hepatitis, HIV, other infectious workup. Patients of younger age, less than 40, you may somewhere consider inherited bone marrow failure syndrome, but they tend to be fairly rare. The classification of aplastic anemia is based on the level of the neutrophil count substantially. Very severe aplastic anemia has a very low absolute neutrophil count, less than 200. Moderate forms exceed 500. 500 plus on the absolute neutrophil count is actually not that bad. And we usually don't panic about this. Severe is somewhere in the middle with your ANC and how the other counts are affected. Very severe is characterized by a very low ANC. The treatment is essentially immunomodulation or suppression through ATG, anti-thymocyte globulin from the horse, at least up front, not the rabbit, but I don't think this is going to be a question. So horse ATG in combination with cyclosporin and a few weeks of prednisone, but mainly to avoid serum sickness at the beginning, not to treat the aplastic anemia. Steroids are not good for that. The response rate is somewhere in the range of 70-80%. The relapse rate still substantial, about 30%. There's a risk of aplastic anemia turning into a clonal disorder, such as MDS, PNH, actually, or acute myeloid leukemia, maybe at the range of 5-10%. You would usually pick this up, obviously, by blasts showing up and by cytogenetic abnormalities that weren't present before. Supportive care. Growth factor use in aplastic anemia like G-CSF, EPO does not help. This is not part of the treatment, not even part of the supportive therapy. Pure red cell aplasia is a condition with severe anemia, lack of reticulocytes and bone marrow erythropoietic precursors, but otherwise normal white cell count and normal platelet count. So this is not a pancytopenic condition, as the name implies. It's a pure anemia, oftentimes secondary. A good example here is parvovirus B19 infection that infects specifically erythropoietic progenitors. It's sometimes associated with thymoma and other autoimmune diseases and other conditions, including drugs. A somewhat related condition is large granular lymphocytosis, or LGL. These are lymphocytes with a lot of cytoplasm and granules in it, which they usually shouldn't have. Lymphocytes have very little cytoplasm, it's almost all nucleus, and certainly no granules. So these are abnormal type of lymphocytes that have a particular surface marker profile. You may find T-cell receptor gene rearrangements in some of those cases, but not always. They occur also often in association with rheumatic conditions like Felty syndrome and so on. The treatment of puretal aplasia is somewhat similar to aplastic anemia. Nevertheless, yes, you provide supportive care transfusion support, but it's also based on immunosuppressive therapy with ATG, cyclosporin. Prednisone is used probably more frequently here, or other immunosuppressive drugs, cyclophosphamide, methotrexate, and so on. In patients with otherwise preserved immune function, they may actually recover spontaneously from, say, parvovirus B19-related PRCA if you give them enough time.